Thank you. It's a pleasure to be here and to present on our study about HIV treatment initiation among injection drug users from right here in Vancouver. I'll quickly declare that I have no conflicts of interest. Treatment as prevention relies on prompt initiation of antiretroviral therapy after HIV seroconversion. People who use injection drugs are an important risk group for treatment as prevention strategies, and there is an urgent need to scale up treatment among injection drug users. But the barriers and facilitating factors of HIV treatment initiation are not well described in this group. With these considerations in mind, we used data from a long-running community-recruited cohort of HIV injection drug users, HIV-positive injection drug users, to identify modifiable behavioral, social, and structural level factors inhibiting or promoting the initiation of antiretroviral therapy. Our study sample consists of HIV-negative injection drug users in an HIV-negative prospective cohort who seroconverted to HIV-positive status and were then transitioned to an HIV-positive cohort. Our outcome of interest was the time to treatment initiation, which was the date of antiretroviral dispensation. And for this measure, time 0 was the midpoint between the last HIV-negative test and the first HIV-positive test. I'll quickly go over the two cohorts that I mentioned. The first is the VITUS study. VITUS is ongoing since 1996 and is a prospective cohort of HIV-negative injection drug users. Participants are recruited from the downtown east side of Vancouver and are examined by study nurses biannually, which involves HIV testing at each follow-up. Individuals who seroconvert are transferred to the ACCESS study. ACCESS is also ongoing since 1996 and is a prospective cohort of HIV-positive drug users. Participants respond to interviewer-administered questionnaires at baseline and at every 6-month follow-up thereafter. ACCESS also has a confidential data linkage to the HIV treatment provider for the entire province of British Columbia, and this provides comprehensive HIV clinical records, including CD4 counts, viral loads, and antiretroviral dispensations. I should also note that HIV care in our setting is universal and of no cost to the participants. Our analysis included a variety of sociodemographic factors, behavioral factors including a variety of drug use variables, and structural factors including homelessness and incarceration, among others. The majority of these factors are time updated, referring to the last 6 months. We also included engagement in methadone maintenance therapy and a measure of clinical eligibility based on local treatment guidelines, which followed the recommendations of the International AIDS Society in the US. Eligibility was based on CD4 count, viral loads, and AIDS-defining illness. It's important to note that these guidelines changed several times over the lengthy study period, but because of our access to clinical records, we could go back and accurately assess eligibility. We began by comparing the characteristics of our sample at baseline and stratifying by whether or not they initiated treatment over the study period. We then used bivariable extended Cox models to estimate the effect of both fixed and time-updated variables on the time to treatment initiation. We then used a backward selection process based on the AIC value for our final multivariable model. During the study period between 1996 and 2012, the VITUS study recruited 1,943 HIV-negative injection drug users. 133 of those seroconverted and met eligibility criteria for our analysis. These individuals provided 788 person-years of observation, and out of our sample, 98 initiated treatment over the study period at a rate of 12.4 per 100 person-years. The mean CD4 count at treatment initiation was 250, and the mean viral load was 4.6 on a log 10 scale. Here we have table 1, which shows the baseline characteristics stratified by treatment initiation. And we can see here that individuals who were homeless at baseline were less likely to initiate treatment, and those that were eligible for treatment were more likely to initiate. Table 2 shows the bivariable and multivariable associations with time from HIV seroconversion to antiretroviral therapy initiation. I should note here that the bivariable analysis did not find any of our drug use variables significant, and that was unexpected. This part of table 2 shows the factors that made it into our final model. Of note is informal income generation, which was associated with slower treatment initiation. This variable included activities like sex work, drug dealing, and theft. Incarceration was associated with slower initiation as well, while engagement in methadone maintenance therapy was associated with faster initiation. To our knowledge, this study is the first to longitudinally analyze antiretroviral therapy initiation among incident HIV-positive people who use injection drugs, followed from seroconversion to initiation. Our sample exhibited a high rate of treatment initiation, and in a multivariable model adjusted for clinical eligibility, no measures of illicit drug use were predictive. We found factors related to the criminalization and marginalization of injection drug users were barriers to initiation, while engagement in methadone maintenance therapy was a facilitating factor. Periods of incarceration were associated with lower rates of initiation independent of clinical eligibility. Other studies have shown that exposure to correctional facilities is also associated with reduced adherence to HIV treatments. So our findings lend further evidence to suggest that the criminalization of HIV-positive people who use injection drugs interferes with evidence-based HIV care. Our study has some limitations, of course. The sample may not generalize to all HIV-positive injection drug users due to non-random recruitment methods and the universal no-cost availability of treatment in our setting. Some of our explanatory factors are based off of self-report data and may be biased as a result. But several other factors and the time to initiation were derived from reliable clinical records. To conclude, among a community-recruited cohort of HIV-positive people who use injection drugs, periods of incarceration and informal income generation were found to be barriers to treatment initiation. Engagement in methadone maintenance therapy was found to be facilitative of initiation. These findings should be considered in the context of the urgent need to scale up HIV treatment among people who use injection drugs. Thank you. Special thanks to the participants and the research staff. Thank you very much.
Thanks, Brendan. Great presentation. We've got a few moments for questions, so I'd invite people to bring their questions to the floor.
Can I ask a question?
Certainly.
So that's a really interesting finding about the association between being involved in informal income generation and sort of slower or extended time to treatment uptake. Suggests that it's not, with the other findings, suggests that it's not drug use per se, or the types of drugs that people use, but the things that they do to procure or to generate an income to support that drug use. What are the policy implications of that?
Well, if you include incarceration with that and the factors surrounding that informal income generation, you might point to some worries about being incarcerated, worries about if they were to seek out HIV treatment, they might, have to give out identifying information, might be reluctant to do that. Maybe it's a general reluctance to access healthcare in that way. So as for policy, making sure that their privacy would be respected, they aren't at risk of incarceration, things like that, maybe that would help. I'm not sure though. Yeah, suggestion anyways.
We've got a few questions from the floor. Perhaps we'll go on this side and then the back on that side.
Kim Page, University of New Mexico. You went through those slides kind of fast.
Okay.
And there was the variable about time. Was it time in the study or the year of cohort? How did time impact these measures? Maybe you haven't had a chance to look at it. Year of observation, go back. There it was.
Is this the one?
The year of observation.
Yeah.
Yeah. So can you talk about that a little bit?
Yeah,
Because obviously things have changed here, and we heard this great plenary earlier, and so maybe you could comment on that.
Well, the study period was pretty long, 1996 to 2012, and especially in Vancouver, there was a big expansion of access to therapy, a lot of outreach, and I know the requirements, the clinical requirements for eligibility were decreased, the threshold that was needed in those levels. So I would imagine it has something to do with that. Yeah, definitely. That's a good thing for future research, yeah.
Perhaps we'll take the question at the back on this side and then the question on the front on this side.
Thank you. I'm Anna Forbes. I'm an independent consultant based in Washington, D.C. I was actually surprised to hear you say that incarceration was a factor that seemed to interfere or be a barrier to ART use, only because in the United States, for people who use drugs, being incarcerated is often one of the only times when they're getting ARVs because our health system is so bad at providing them. Is there consistent provision of ARVs in prisons and jails here, or is that, why do we see that as something that interferes with people's ART access?
I can't speak to exactly why, but I think it has been getting better with time. There's a lot of research that's coming out of our group that implicates incarceration as preventing or impacting adherence to antiretrovirals in a very negative way. You would think that it's an environment where it would be easy to get people on treatment if they were positive, but it seems like the evidence shows it's not the case around here anyways. But I do think there's a lot of push to change that, and
Thank
I hope it does in the future.
A couple quick questions. I work with this population in Vancouver. I'm Glenn Bowlesby. Did you look at Aboriginal status and as whether that might be affecting uptake of ART?
We had a variable as Caucasian ancestry. And I can't remember, I don't think it was significant. So yeah, I don't think there was any significant findings for that in general.
Okay. Second question about informal income generation. Did that include things like binning and reselling and a lot of the activities that our folks get up to?
I believe it included 3 activities, sex work, drug dealing, and theft. And the other ones, binning and stuff, weren't included with that.
Okay. Thank you.
Thanks.
Well, it looks like that's the questions from the floor, so perhaps we'll move on to the next presentation. Thank you again, Brendan.
Thanks.